All right. Actually, today's Wednesday. The live streams are Thursday, but I'm not going to be here. So actually, today's Tuesday. So I'm pre-recording it for you all. Welcome to the BPH breakdown for BPH BPO patients. Super excited to be with you guys today. And we're going to talk a little bit about, as always, going back over our vision, our mission, who we are, our 4 agreements, and talk about a simpler approach to the IPSS. And if we have time, we might get into a little bit more. So let's get going. All right. Just so you guys know, the camera may go out. And if it does, I'll try and bring it back on. We'll bring the music up a little bit there. And we'll get going. All right. As always, it's important that we celebrate the defenders of the future. If we're going to make a permanent change for the BPH BPO care pathway in a permanent way, the future defenders of the detruser have to understand the vision, the mission, and the goal. And so today we celebrate 2 rising urologists, rising defenders of the detruser, Mohammed Nauman Tariq and Andre Bellarmino from UCLA, as well as from Pakistan. So welcome, as well as all these other wonderful folks here on the screen as the tribe grows in strength and breadth and depth. And that is super exciting for all of us. As always, returning to Defender Amanda Chung's work, showing that there are changes that we need to trust. We need to trust the truth of trabeculations when we're doing cystoscopies. That is a detruser in duress, under duress, as Defender Sunny Schlein tells us, as well as what Dr. Amanda Chung has shown us at a histologic electron microscopic level, that there is death and destruction of those detruser cells. And remember our triple P's of the ManVsProstate crusade. We are here to prioritize the preservation of bladder health. We are here to put an end to the polypharmacy epidemic, as well as to prevent late-stage BPH BPO. And with that, we know that the 5 stages, I introduced that during the pandemic with the ebook, 5 stages of bladder health, where the late stages are stage 3, urgent incontinence, stage 4, acute retention, stage 5, detruser underactivity, or bladder failure. And we continue to celebrate the Italian Brigade being led by Defender Luca Sindolo for getting that, taking the torch and putting it into print at the Prostate Cancer and Prostate Diseases Journal. Please visit ManVsProstate.com, subscribe, and get a free copy of that, as well as a free copy of the ebook. Because a tsunami of late-stage BPH is already crashing into the shores in Europe, in Scandinavia, and is beginning to crash here in the United States. We need to come together to devise a BPH BPO care pathway that's personalized, that's effective, efficient, simple, and safe for our patients. And with that, we have now migrated from the dry erase board in my kitchen of my office and now starting to put together more formally a way to risk stratify bladders. And today we're going to talk about a little bit more of the role of IPSS. And we believe those bladders at risk can be screened using a consensus that if they have an IPSS that is moderate to severe with a Qmax of less than 15 and or a PVR more than 50 cc's, that those folks are at risk and may need, they need a bladder health baseline using cystoscopy for the qualitative data of trabeculation, cellules, diverticuli, as well as pressure flow studies when available, because we need to define what's going on with the bladder pressures, especially do they have detrusor underactivity. And so with that, obviously this is the traditional IPSS score where it's broken down, right? There's 7 items, voiding subscore, as well as a storage subscore, with the storage subscore or the irritative symptoms being indicative of whether or not that bladder is under distress and that we need to step in and defend it. IPSS suffers from the weakness of anamnesis brought to us from Defender Sonny Schlen. You know, I've got to reach out. Please tell me, how do I say your name properly? I apologize. I need to reach out to you, Sonny, and find out how you say that properly, and I apologize. However, with that said, he has taught us the term anamnesis, a calling to mind. It's a recollection, a remembrance. And that's where a lot of our BPH BPO patients suffer, is recall bias. I mean, I can barely remember myself what happened yesterday. How are they going to remember their symptoms over the last 30 days? And before we jump in, as always, on this day in history, for us to know what we need to do now for a better future, we need to look to our past. And for our globe, for our world, in 1919, the League of Nations was founded. In 1924 was the first Winter Olympics. And in 1947, on this day, the first arcade game was patented. And in 1971, dictator Idi Amin seized power in Uganda. And in 1977, the world's first solar power plant opened on this day in history. And with that said, 39% believe that IPSS is not predictive accurately of bladder outlet obstruction. What we know now is that IPSS does a poor job. It is insufficient alone to create diagnostic certainty for what's going on in the bladder. In this pivotal paper that came out last year in the Canadian Journal of Urology by defenders Tobias Kohler, Sankar Kaushik, as well as David Mahoney from SRS Medical. Together, they've put together a great piece of data for us all to look at, understanding that if you look at the spectrum from unobstructed in green all the way out, where we see obstructed in red, the distribution of IPSS is very similar across the spectrum of disease. It cannot discriminate who is obstructed, who is not obstructed. And if we go in more detail here, we'll see that its sensitivity, if we look within the obstructed population, we are missing 1 in 4 who may need our help with deobstruction, but they report mild IPSS scores. And the specificity, if we look at the subset who are unobstructed, 60% are being mismanaged, potentially with the wrong diagnosis of BPH BPO. Where 60% of them have moderate to severe symptoms, and they may be receiving potentially even surgery when they may not even require it. And then we asked, for asymptomatic men, what percent are non-obstructed on a pressure flow study? 11% thought that in that subgroup of healthy asymptomatic men, 75 to 100% of them would be non-obstructed. When in truth, those who voted that 50 to 74% are non-obstructed would have been correct. And we saw this with this study out of 2001 by Walker, where actually looking at these asymptomatic men, only 58% were actually non-obstructed. And what that tells us is that the patient is not a reliable witness for the bladder. It's been guilty. We men, our patients, are guilty of bearing false witness to their bladders. They are knowingly stating as fact that which is untrue, because the bladder is often not doing well, yet men will respond to the physician by saying, hey, I'm fine. But in truth, they are not fine. And in truth, the IPSS may mean playfully the imaginative prostate subjective symptom score. Because in truth, one, it's not about the prostate, it's also about the bladder. And these are very subjective symptom reporting that suffers from recall bias. And as a result, we need to be very thoughtful about how we use the IPSS. And in order to do that, we need to first kind of talk about, is there a better way to do the IPSS? And before we jump in there, always we need a wellness quote. Your time is limited. Don't waste it living someone else's life. And that was from Steve Jobs. What we've learned about IPSS is that education matters. In this study in 2008, they found that the reporting on the IPSS or the AUA symptom score is influenced by sociodemographic variables and reading comprehension. In 2008, in Emory University in Atlanta, Georgia, they looked at about 1,000 folks with an average age of 63. And what they found is that they actually had someone do the IPSS with a physician, and then they also had them self-report, and they compared the two. And what they found is that patients with a lower education misrepresented their scores more often. So education does matter for IPSS. Well, how about making it more visual? I think this is a great little study in South Africa, Tygerberg, 78 folks with urethral strictures. And on the right, you can see just a great use of visuals to help define potentially how the severity of the obstructive and irritative voiding symptoms. How about adding some color? Here's another nice study in 2021. Once again, love the visuals, love the colors, which can be a very good way to communicate with our patients. But I think something which we need to recognize is the future is bright for the BPH BPO care pathway because we have up and coming stars, future defenders of the detrusor like Luca Morgantini, who's actually a resident in Chicago, did a lovely presentation for the International Continence Society, looking at a new version, a simplified version of the IPSS. Shout out to the Department of Urology in Chicago at the University of Illinois, as well as the Hospital Universitario Puerto del Mal in Cadiz, Spain, for these authors. They recognize that, at least here in the United States, too many men have now reached a literacy level of level 1 or below. And what that means is that they are at risk for difficulties using or comprehending printed material. They can read short texts to perform simple tasks, but drawing inferences may be too difficult. And as we see this decline in literacy here, at least in America, is there a better path forward for the IPSS? And yes, let us make it simpler. And so what they did was they actually simplified the reading level of the IPSS, which was traditionally at an 8th grade reading level, and they brought it down to a 4th to 5th grade reading level. They did great things like just very simple gestures to make things more comprehensible. So instead of going, hey, over the last month, have you had the symptoms? They said in the past 30 days. Instead of using the medical term of urination, they just kept it simple and called it pee. Instead of using a term like postpone, they used the term holding. And to strain became push. And quality of life became, how do you feel about your peeing? And they were able to provide a range from dissatisfied to satisfied. Playfully, I would say, can we just change the IPSS from International Prostate Symptom Score to the International Peeing Symptom Score? I think that'd be more inclusive to include both the prostate and the bladder. But I think that's a tall order to ask for. But as my colleagues in primary care, I like how they just call it the IPSS survey to keep it really simple for their patients. And this is a simplified IPSS, and what they were able to do is actually compare it to the traditional IPSS and found that they had very similar results, but it was in fact much easier for the patients to be able to use and interpret in English as well as in Spanish in this small series. And so at this time, I would say, let's keep things simple and use a simpler IPSS as proposed here potentially. Totally open to discussion about this. Please comment below. Why do I think it's good just to make this small modification to the IPSS? Well, we need to preserve the integrity of the huge body of research work that has been performed using the IPSS as we know it. In order for us to be able to make comparisons to the past for future technologies, for both diagnostic and therapeutic, we need some measure that we can compare from the past to the present to the future, and that would be the IPSS. A second reason to keep the IPSS, but maybe make it simpler, is it is a better match to the literacy levels of the modern man, at least here in America, where unfortunately, sadly, it is in decline. Third, I think it's the least disruptive. Wow, let me try that again. It would be the least disruptive to our current BPH BPO pathway, just to make a small modification to our current IPSS to allow us to continue the momentum, because the end goal is to be able to screen men to find which bladders are at risk for death and dysfunction. And so whether we use a traditional IPSS or the simpler IPSS, they both serve a very similar primary purpose, which is that it is an invitation from the provider to the patient, from the patient to the provider, to engage in a shared decision-making process that is pro-diagnostic, data first, and bladder-centric. And so with that, I just wanted to end. Thanks for allowing me to share some of these thoughts. See if, check out the simpler IPSS. I think there'll be a link down below where you can see it on YouTube. There'll be a QR code that you can then download it and see if it might work for your patients. Once again, audit your own data. Maybe give 10 or 20 of your own patients the traditional, another 10 or 20 with the, 10 or 20 of your patients with both of them, and see how they compare. And just be able to look at your own data for your own patients and be able to interpret that. All right. Well, I think it's a real pleasure. Thank you so much. This is pre-recorded. I'll get that out to go live this Thursday. And I look forward to seeing you guys next Thursday. All right. Have a great one. Bye.